We're going to get started. Good afternoon, everyone. Thank you all for coming today. This is the Budget Sub 1 hearing on the special session proposals. Today we will hear the proposals in health services. As I mentioned yesterday, I anticipate that many of the proposals discussed today will be referred to the regular subcommittee process for further consideration. But this special session compels us to begin to hear the proposals, some of which the administration will present their proposals, some of which we've seen before, and some of which are entirely new. We'll then allow members to ask questions and then to accept testimony from the public on the proposed reductions. The gravity, magnitude, and drastic nature of these cuts, eliminating legal immigrant programs, massive cuts in Medi-Cal, and eliminating adult day health care, requires much more time to consider real human impact, the impact on the economy, jobs, and involved with these programs. Real cost shifts to other programs that are not accounted for in the governor's budget, and real loss of federal funds, which we're currently receiving at enhanced levels due to the federal stimulus. This is a complicated discussion that will require serious time and attention. Today we look forward to hearing from our departments, program and consumer advocates, and the public, because we will have so many people with input. And we experienced yesterday, our hearing went for about almost 5.5, 6 hours. So we'd just ask that you keep your comments to about 2 minutes if possible. And what I'll probably do is, if you see me raise the pen and kind of shake it a little bit, you'll know you're at about minute 45, and that you'll know to kind of cut it a little short. I apologize for having to do that, but we want to hear everyone, and a lot of people have come from around the state, and they have to get back, and it's just not fair for people to go on too long, and I think we can all say it probably within the 2-minute time frame. So thank you all for being here, and we will make one change in the agenda that you have. On the Department of Health Care Services, which is the third item down, the 4260 programs, we will move issue 8 up to issue 1. So that will be issue 1 after that, and then, but it will be issue 8, but it will be taken first in that category. So without further ado, if we could have the departments and the LAO's office and finance come forward, and we'll begin the hearing. And other members, as you know, we are still in recess of our legislative session for the day, and we may be called back into session at the call of the Speaker, and that could occur at just about any time this afternoon. So you'll have to bear with us when that happens. And other members will be here shortly. So, good afternoon. And I'd like to begin from the department's point of view. We're talking about Department of Public Health, and this is the eliminate the use of AIDS drug assistance at the ADAP program in county jails.
Good afternoon. I'm Michelle Rowland, the Chief of the Office of AIDS. This proposal from the administration would result in a policy change where county jails would no longer be eligible to participate in the ADAP program. This would impact 44 jails in 36 counties. We're estimating general fund savings as a result of this change of $9.5 million, which includes a reduction in our expenditures of $11.2 million. So it would be that expenditure reduction that would be shifted to the county responsibility. Yeah. Counties are currently responsible for providing medications to jail inmates, so they would use their existing systems to purchase, as they purchase now, their medications and to fund the medications. The only thing that ADAP does, we don't actually purchase the drugs and provide them to the county jails. We just reimburse the jails that the pharmacies that are servicing those jails for the cost of those drugs. So that's what the proposal is.
Is there a cost shift at all in this related to the counties then? Obviously, if we're not providing those funds and those inmates require those drugs and medications, the counties will then have to pick up those costs. Is that correct?
Right.
Okay. Thank you. LAO's response?
Thank you, Mr. Chair. Lisa Morawski with the Legislative Analyst's Office. We are working with the department to see if an alternative proposal makes sense, an alternative proposal that would mitigate some of the cost shift down to the counties.
Well, that's good. Well, we'll look forward to seeing that. Anything from finance? Nothing. Thank you. Questions from this? So what we will do is take, at the end of each issue, we will have public comment on that particular issue item so that we can move it through accordingly. So we'll now take public comment. Michael?
Hello, Michael Martinez of Manette Phelps & Phillips here on behalf of the Center for AIDS Research, Education, and Services of Sacramento Valley's largest HIV/AIDS clinic here. And to the LEO's point, look forward to working with them on an alternative proposal, because certainly we do want to make sure that individuals living with HIV and AIDS do receive access to these life-saving drugs, and so there is no interruption, as well as we are concerned about the cost shift to counties, considering that they are expected to take in a lot of many cost-saving proposals in past budgets and certainly in this one as well. So very concerned about the cost shift to local government. Thank you.
Thank you very much, Michael. Yes,
Hi,
good
I'm
afternoon.
Mary Silla with the Center for Health Justice, and we're also opposed to this. We work specifically on HIV issues related to prisoners, both in county jails and in state prisons in California. And as you know, for over a decade, California's ADAP has covered the cost of these HIV medications, except for a lapse of several years in Los Angeles County, and that lapse actually is the reason I got into this issue. The State Office of AIDS has provided this subsidy based on the fact that most jail inmates are ADAP clients prior to their incarceration, and that any interruption in medication would result in higher cost to ADAP, probably long term, and a cost to the public health system in general. So these cuts threaten the individual and public health and also don't make fiscal sense. And it's going to place the financial burden of these medications, as you noted, back on the county governments. And in Los Angeles County, we know what happens when county jails are responsible for providing HIV medications, because it happened in the late 90s, and it resulted in people going without their HIV medications for a matter of weeks. They weren't able to receive commonly prescribed HIV medications in jails. People missed doses and risked developing HIV disease resistant to treatment, and with their virus uncontrolled, became more likely to transmit HIV. And it's important, as you may know, to maintain your HIV treatment 95% of the time, so even a relatively short amount of time of missed doses could result in resistant virus. This savings is just being transferred back to the counties, and the counties are already going to be receiving state prisoners back under other proposals and more parolees back on the streets. So because of how efficiently ADAP runs, it's probably more cost effective for the state as a whole to continue to run this through ADAP. And I just think the counties, which are already overburdened, and the county jails, which are already overburdened, are going to have a much harder time of funding these. One final note, right now county jails typically provide release meds to people being released from county jail, because they anticipate that you will not be able to get hooked up with medical services immediately upon release. I've been told by the Los Angeles Sheriff's Department that they will likely discontinue that immediately, because they have no legal responsibility to provide those meds for people who aren't in jail anymore. Thank you.
Thank you very much for those comments. Appreciate it. Good afternoon.
Good afternoon. I'm Lieutenant Wayne Billowit with Los Angeles County Sheriff's Department, and I'm going to try to make it real brief. I'm going to do my best Joe Friday here and just stick to the facts. The Los Angeles County Sheriff's Department operates the largest municipal jail in the nation. To give you some real numbers as to what this is going to impact, we treat about 240 people a month under the ADAP, which is an enormous amount. We spend about $3.9 million a year on these medications alone. We get about $3.2 million in reimbursement. That's an enormous amount of money out of our medical budget that goes to these medications that we get reimbursed for. So a cut in this will make a severe impact to what we can do, our aggressive testing, and like the speaker before me said, currently we're trying to provide as much medication for people immediately after they get released as well. That would probably have to stop as well. So we urge an opposition to this. Thank you.
Thank you for making those points.
My name is Aaron Fox from AIDS Project Los Angeles. We are also not in support of this, and we believe, like the speaker before me, Mary said, that with additional provisions that might go through in the budget, funneling more people into county jails, that this could cost LA County upwards of $7 million additionally. And we believe that this is not something the county can do, considering that it's already considerably cash-strapped.
Great, thank you.
Good afternoon. My name is Curtis Hill. I'm the sheriff from San Benito County, and here representing State Sheriff's Association today. I echo my public safety colleagues in the opposition to this measure. We have Just one more cost shift from the state back to the county. My biggest, and all sheriffs, our biggest costs are meds. There's high-priced meds when we talk about the psych meds and to drive 17% of our population. Now on top of that, we're going to add even a higher cost of a medication in a very critical group. So I oppose as well. Thank you.
Thank you very much, Sheriff. Thank you. That concludes the public comment on issue 1. Seeing no committee comments, we'll move to issue 2, the technical federal fund shift.
Yes, so this is a current year proposal to shift $3.5 million of federal funds from state support to local assistance. This proposal results from the loss of general fund in the current year for the Office of AIDS prevention and care programs. As a result of the reduction in our total resources, we reorganized our programs that are funded by our federal funds and emphasized trying to make sure that we had met the maximum amount of money available for programming. So since we had fewer resources for programs, fewer programs, we were able to reduce our staffing and shift that money to be able to provide local assistance services.
Very good. LAO's analysis, nothing? Very good. Finance? Yes,
Jacob
sir.
Port, Department of Finance. Would only point out that it would begin in the current year, but it is an ongoing shift, so it's permanent.
Permanent shift. Okay. Very good. Seeing no questions, and we have no one from the public, we'll move right on to Managed Risk Medical Insurance Board. Issue 1, reduce children's eligibility in healthy families from 250% to 200% of poverty. Good afternoon.
Good afternoon, Mr. Chairman and members. I'm Leslie Cummings. I'm the Executive Director of the Managed Risk Medical Insurance Board.
Maybe a little closer to the microphone. I just want to make sure everyone gets an opportunity to hear. Be appreciated.
I'm Leslie Cummings. I'm the Executive Director of the Managed Risk Medical Insurance Board, Mr. Mibb, and beside me is our Chief Deputy, Jeanette Casillas. We're here to talk to you about the governor's proposals in special session concerning the Healthy Families Program. On page 4 of your agenda, as your committee consultant describes, the governor has proposed reducing eligibility for the Healthy Families Program from 250% of the federal poverty level to 200% of the federal poverty level. The budget assumes that this change would take place on May 1st, which would require enactment of trailer bill language by March 1st in order for us to make that change on that date. Of course, most of the savings would be occurring in the budget year since the change would be being made at the very end of the current year.
Okay. Thank you. Anything further from administration on that? The LAO's response?
This option would provide savings, and we consider it as an option. If the legislature does not wish to eliminate eligibility for this category, we would advise raising premiums in this eligibility category.
Okay.
Mr. Chairman, I neglected to mention,
yes,
just so that everybody's clear, what this would mean is that on May 1st, we would disenroll all children whose families have incomes between 200 and 250% of the federal poverty level.
What was the date again? I'm sorry, May?
On May 1st.
May 1st, right.
We would disenroll.
Okay. All right, thank you. Finance?
Yes, we would just note that currently of the 39 states that have standalone S-CHIP programs, 18 of those have a maximum income eligibility that is at 200% or less. And originally the Healthy Families Program was at 200%, and then in its second year was expanded to 250. So in effect, we would be going back to the original eligibility level for the program.
All right, thank you for that. Mr. Bell?
When I looked at this, I had, I wanted to ask the experts what they thought of this. would this result in government cost in terms of health care by moving people into Medi-Cal, or by having less net money because they have to pay premiums? And then would it involve government expenditures in other ways, or making the children not eligible for other programs beyond the healthy family, like food programs and other programs? Can you address the implications of what we're talking about here?
The question is, what happens to uninsured children?
And what happens to these kids? 200,000 or whatever.
And specifically to your question about Medi-Cal, there may be a very small percentage of these children that would qualify for share of cost Medi-Cal, but it would be extremely low.
Okay.
And in terms of where else would they go for care?
Right.
They would go where uninsured people go for care, which is some choose to pay out of their pockets for doctor visits. Some go to clinics. Some may try to go to county clinics. Some may go to the hospital and end up with, if it's an expensive case, they may end up with, the hospital may end up with uncompensated care. The family may end up with medical debt. It's all the things that happen with uninsured people.
When I was chair of the Santa Clara Family Health Plan, we started our Children's Health Care Initiative, and many counties have those kinds of programs. Would you think some of the kids would then go into those kinds of programs and burden? I know those programs don't necessarily have a lot of money, because I don't think our program can absorb such large numbers, but would that be a problem also?
Well, it would likely create a demand. As you note, I don't know how the degree to which those programs could respond to the demand, as you know better than anybody, where those programs tend to have money for coverages from 0 to 5-year-olds, but not for children over age 5. And so it would be, there might be a demand on them for service, but I don't know whether or not it's something they could respond to.
Well, I think my question is, I think we need more study on those kinds of questions. I would imagine that some of the kids would then go into those programs. I would imagine some of the costs would be local, some would be state, some would be federal, maybe. I would imagine there'd be more acute care as opposed to preventive care, and that should be looked at. So what I'm trying to get at is, I think when we do these kind of things, we should look at what the implications are in real life situations in terms of the state budget and then what it's going to cost. And I think, you don't just take 200,000 kids out of a program and expect that there's not going to be any health care cost. It's going to come from somewhere. So.
Thank you, Mr. Bell, and I think you're absolutely correct. The cost will be there'll be a shift, and in most cases it'll go to the counties, who will the provider of last resort, and so it's just another shift downward, which is not what we want. I'm hopeful that this year, just as with the ADAP program that you're working on now, we can come to some solution to avert the disenrollment of the 200,000 children before this process ends, because that's a number that I think would be difficult for us to fathom or to live with in California. So with that, thank you for the comments. We'll now be in a public comment. Good afternoon, sir.
Good afternoon. Cliff Sarkin on behalf of the Children's Defense Fund and the 100% Campaign, a coalition of children's health advocates. And I'm joined today by Dr. Marcella Spera from Oakland Children's Hospital, who will be able to talk in greater detail about what you, Mr. Bell, were wanting to know, the effects on the ground of children who don't have health insurance needing to seek coverage in the emergency room. But before she talks, just a little bit of policy perspective as to what this kind of cut would mean. First of all, it would be the first time in the history of the Healthy Families Program that we actually cut children from the program. Last year, due to the budget shortfall, we had to impose a waiting list for 2 months for the first time, but this would be literally the first time we're kicking kids off coverage. The 204,000, what that means, roughly the last time we got data from UCLA in 2007, there were 689,000 uninsured kids. So increasing the ranks of uninsured children by 200,000 would be a 28% increase in the uninsured children's population. And as you said, Mr. Hill, this basically just passes the costs off the state ledger into the counties. We all know what happens when children don't have health insurance. Parents wait till they get more sick, till they eventually have to seek care for acute conditions in the emergency room. Costs go up. Families can't pay it. Bankruptcy becomes an issue. Certainly, we know from our experiences from data that having health insurance is a timely investment and certainly prevention rather than needing to seek acute care. So I'll let Dr. Sparrow talk about what that means in the hospital.
Thank you. Good afternoon, Doctor.
Good afternoon. My name is Marcella Spera, and as I was introduced, I'm a pediatrician. I work as a hospitalist at Eden Medical Center in Castro Valley and with the adolescent department at the Children's Hospital of Oakland. As a pediatrician, I see firsthand on a daily basis the difference that healthcare makes in children's lives. There's no doubt that regular access to healthcare prevents children from getting sicker. As an example, I'd like to tell you about a baby that I saw just last week. This is an 8-month-old infant whose father lost his job and subsequently lost the family's health insurance coverage shortly after she was born. Because of this, her family was never able to establish regular care with a primary care pediatrician. This relatively healthy infant was seen in the ER twice within less than a week for a respiratory illness. The first time she was brought in for a bad cough, she was diagnosed with bronchiolitis, which is a fairly common viral infection of the lungs, but it can cause severe inflammation and it can cause difficulty breathing in young babies. A small portion of these babies respond well to inhaler medication, and luckily she did. She was appropriately prescribed inhaler medication by the emergency room staff, but she had no pediatrician to follow up with. She got progressively worse. Her mother noticed that she was actually struggling to breathe, brought her back into the ER a few days later, and as I was talking to the mother, I asked her to show me the medication that she was prescribed. Unfortunately, there was an error in the dispensing of the medication. While it was correct, she wasn't supplied with the right apparatus so that the infant could receive the medication effectively. There wasn't the appropriate spacer and mask. The mother had no primary care pediatrician to seek counsel from, and so she tried to do her best, but the baby got worse. She came in and her oxygen levels were quite low. Luckily, she did respond to another treatment in the emergency room, and we were able to get her the right equipment. But she almost required hospitalization. Luckily, we got her oxygen levels up, and I was able to discharge her home. But I felt uncomfortable sending her home without any follow-up. And I actually recommended to this family that they, because they already knew they couldn't qualify for Medi-Cal, and I urged them to apply for Healthy Families. And so just soon after that, I heard about these potential cuts that are being proposed, and I just thought that this is a really clear example of how a relatively common illness got much worse and almost ended up in hospitalization, and how emergency room services were being sought rather than routine clinic appointments. By denying hundreds of thousands of children access to medical coverage, we'll witness more cases like this, and the consequences for the life and health of these children could be much, much worse than they ended up in this case. I urge you to oppose the governor's proposal to cut Healthy Families and Medi-Cal program and to ensure that we preserve the health care coverage for children that are already enrolled in these programs. Thank you.
Thank you, Doctor. Good afternoon.
Hello, Erin Auber-Givens on behalf of the Children's Specialty Care Coalition, and I support the previous comments in regards to the proposed general cut in eligibility to the Healthy Families program, but wanted to bring particular attention to the results of this cut on 5,000 to 8,000 children with CCS coverage. These are children with catastrophic and chronic health conditions such as cancer, congenital heart disease, cystic fibrosis, where really coverage is a matter of life and death and a matter of whether they can continue to receive this care. For a portion of these kids, they would be shifted back to the county. We would lose federal matching funds, and it would be 100% state-county funds. The rest of the children would be uninsured. And just to give an idea, your analysis correctly points out that CCS eligibility, apart from healthy families, is not adjusted for family size. So it's just straight $40,000 without any of the income disregards that are used for Medi-Cal and healthy families. So for a family of four, 250% of poverty is over $55,000 a year, just to give some perspective on that. Thank you.
Thank you for that clarification. Good afternoon.
Hi, good afternoon. My name is Nancy Lee. I'm here representing PICO, California. PICO is a network of 20 congregation-based community organizations representing more than 450 congregations and over 500,000 families in California. As you just heard from Dr. Spera, she talked a little bit about the struggles of one family trying to find health coverage for their child. Now, if you can imagine multiplying this situation times a million, that's a devastating impact of this budget and the impact on our families. It's simply unconscionable that the governor would even consider eliminating healthy families. So we understand that, we are in hard times and some tough decisions will have to be made. But to balance the budget, I think we need to look at priorities. And I can't think of a priority that's more important than the health of our children. Kicking children off health coverage is just a foolish decision that will harm our economy, our healthcare system, and most of all, it's going to harm the health of our children. Uninsured children still need health care, as Dr. Spera spoke to earlier. They end up in more expensive care like the emergency room, which in the end is going to cost us more, the state of California more, and also our families more. So we strongly urge the legislature to make the responsible choice and reject this budget proposal. Thank you.
Thank you.
Good afternoon. Tahira Bazil with the California Primary Care Association. We represent over 800 nonprofit community clinics and health centers across the state. And to speak to Assemblymember Hill's comment, not only will this cut create an additional barrier to care for the children, but it will create an additional burden to the already overburdened safety net system, of which community clinics and health centers are a significant component. Community clinics and health centers will continue to treat these children, not only because it's the right thing to do, but because we're federally obligated to serve anyone who comes through our doors regardless of their ability to pay. So adding to the uncompensated care threatens the clinic's ability to remain financially solvent, keep their doors open, and continue serving children in our communities. So we hope that you reject this. Thank you.
Very good. Thank you.
Good afternoon. Stephanie Hodson with United Ways of California, representing the 37 local United Ways across the state. And like our colleagues at the 100% campaign that you've heard from and the California Children's Health Initiatives that you're about to hear from, we're opposing these cuts because eliminating these coverage programs puts children's lives at risk. And additionally, it doesn't bring savings to California. In fact, it only worsens the budget problems that this committee is looking to try and solve. Hurts our economy by giving up federal dollars and forcing children into more costly types of care, like we heard from Dr. Spera. By cutting the Healthy Families program, California would lose this needed federal funding, and our economy and our state budget are already in desperate need of every dollar available, and we can't afford to forfeit the potential federal dollars that come from this program. Cutting Healthy Families also increases costs for businesses and families as more children are being shifted into more expensive types of care, and providers are forced to pass those increased costs on to those with private insurance. So we would urge you to reject the governor's budget proposal.
Thank you. Good afternoon.
Good afternoon. I'm Ann Millar with the California Children's Health Initiatives. Collectively, our members provide health coverage to over 70,000 children in 29 counties through California. And the CHIs have played a unique role in identifying and enrolling thousands of kids in the Healthy Families and Medi-Cal program since 2001. The need for affordable health care coverage programs like Healthy Families has never been greater, as unemployment rates skyrocket and more Californians lose employer-sponsored health coverage. The number of uninsured children continues to rise as job losses make private insurance less available and more expensive. By cutting and eliminating coverage programs for children, families will no longer have the security of knowing that a playground mishap or flu outbreak won't plunge them deeper into debt. Now is exactly the wrong time to cut critical, cost-effective coverage programs like Healthy Families. It would devastate the lives of our kids and our families. Kids have everything at stake in this debate, and their lives are literally in your hands. We urge you to reject the governor's cuts, protect the lives of children, and invest in what matters most, the future of our kids. I'd like to introduce Mr. David Cepeda. He is a Healthy Families parent.
My name is David Cepeda, and this is my daughter, Lydia, at 2 years old. And I'm here to say a few words about Healthy Family. I am grateful for Healthy Family that my daughter, she's up to date in her immunization shots. And right now, at the moment, I'm not working, but my wife is. At one point, she tried to add us both onto her insurance, but it was too costly. Cost was too high. So somehow somebody told us about Healthy Families, and we were able to get help from them. And like I said, up to this date, she's had all of her shots, and I am very concerned for the kids who don't have their shots up to date at this point. A lady for Healthy Families was telling me, a worker employee, she urged us very much to have her shots, all of her shots taken. In her case, her parents did not take her in for her shots, and she was I'm trying to look for the word, but at this time she has polio just for not having all her shots taken. So I do ask you that this afternoon. I encourage you to not take anything away from Healthy Families, and that's all I have to say. Thank you.
Thank you for coming today and sharing those thoughts. Appreciate it.
Mr. Chair and members of the committee, Carolyn Gino with the California Medical Association. California's physicians are opposed to these proposed cuts. As of May 1st, the proposal would leave 200,000 children without coverage, and the change in eligibility would result in over $5,000 per month for the remainder of the year being denied. So we're going to add $250,000 to the ranks of California's uninsured. In addition, the proposal to shift some first five monies over to the general fund to patch up the hole leaves us unsure as to whether funds would be available to ensure the continued stability of this program. Last year, the legislature did a wonderful job in putting together solutions to keep this program afloat, and we would hope you're able to do that again this year. Thank you.
Thank you.
Thank you, Mr. Chair and members. Nick Luizos with the California Association of Health Plans, representing plans that participate in the Healthy Families program. We're in opposition to the eligibility reduction. Last year, if you remember, the health plans and others banded together to pass Assembly Bill 1422, which established a financing mechanism, which was essentially an assessment on a segment of our industry and other programmatic changes that help stave off massive disenrollment in the program. So we find ourselves concerned and disappointed to be here in opposition to an eligibility reduction that goes in the opposite direction of that. However, we do understand that nothing but hard choices await the legislature and the governor, but we had to express our opposition to this proposal. Thank you.
Thank you.
Thank you, Mr. Chairman and members of the committee. Maureen O'Haron, representing Molina Healthcare of California. We're one of the managed care plans in the Healthy Families program. We strongly support this program and its leadership and staff, but we really, really oppose this cut. And we were one of the plans that supported and backed AB 1422 last year, and we hope that we can find as creative a solution this year. Thank you.
Thank you.
Thank you, Chair and members. Kathy Mossberg, representing the Local Health Plans of California, also an organization who works with folks in these programs, in the Healthy Families programs. We just want to highlight one thing, and I think it's been highlighted here tangentially, but these are working families. This fills that gap of people who work for small employers, maybe some moderately sized employers, but don't have health care coverage. And so what we've heard also then to highlight this from the clinics is that then these folks would have nowhere else to go but to a really strapped safety net system of clinics and public hospitals and other hospitals. And so we will just we'll end up seeing folks not getting preventive care like the gentleman here highlighted, and we'll be seeing them with much more acute care. This is an incredibly cost-effective program, and we are also one of the organizations that worked on 1422 last year along with the legislature to work out a creative solution. We urge you to reject this cut and work further to try to figure out other places to work creatively. Thank you.
Thank you.
Hi, my name is Carrie Sanders. I'm here on behalf of the California Pan-Ethnic Health Network, representing the Having Our Say Coalition. We are a statewide coalition of over 50 organizations that work to ensure that health solutions address the needs of communities of color, and we also are in opposition to this proposal. Thanks.
Thank you.
Chancellor Latina Coalition for a Healthy California, also hoping that you'll seek other
avenues other than cutting this program. Just as a reminder and to sort of echo things that the doctor said earlier, this is sort of antithetical to what we've been trying to achieve as far as shifting from acute care to prevention. And it's particularly important with children. And we want to make sure that we're addressing any conditions early so that it becomes more acute later on. So thank you very much.
Very good. Thank you.
Hello, Michael Martinez here on behalf of Ultimate Health Services, the state's largest community health care clinic located in Los Angeles and Orange counties. I agree with many of the comments here expressed today and ask for you to reject this particular proposal. This is really a life-saving program and truly cost-effective. Thank you very much.
Thank you, Michael.
Hello, Mario Guerrero with, on behalf of the California Lesbian, Gay, Bisexual, Transgender Health and Human Services, a project of Equality California Institute. Our network is a coalition of providers, researchers, and community centers providing vital health and human services to the lesbian, gay, bisexual, and transgender community in California who rely on the state's health safety net. Census LGBT people, census data show that children of same-sex partners are twice as likely to be poor as children in opposite sex couples. The governor's proposed cuts to public benefits in this case would be a drastic impact on these communities. We also oppose these cuts. Thank you.
Okay, thank you very much. Okay, we'll finish with public comment on this issue, bring it back to the committee, and we'll take roll since we now have a number of members here.
Hill.
Here.
Bell. Brownlee. De La Torre. Emerson. Hernandez. Nestande.
And let it be known that Mr. Bell is here. He's just stepped out. We'll now move to the second issue in Managed Risk Medical Insurance Board, and that's the elimination of vision benefit and increased premiums paid by families. The department's proposal.
Yes, Mr.
Thank
Chairman
you.
and members. Another one of the governor's proposals that he has advanced to you in special session are proposals to eliminate the vision benefit in the Healthy Families Program as of July 1st, and also to increase premiums for families with incomes between 150 to 200% of FPL. The reason, as your committee consultant's chart demonstrates, that premiums are not increased for the higher income population is because the governor has proposed eliminating that population. You can see that what the increases in premiums would be in Category B, which is families with incomes between 151 to 200%, on your consultant's chart. These, as I said, these changes would take effect July 1st and must be authorized in legislation.
All right, thank you. Does the LAO have a response?
We recommend the legislature adopt this proposal for general fund savings.
Thank you. Finance?
Yes, we recognize that these are difficult decisions. We just wanted to state that in 2009, other states that were facing budget deficits also increased their premiums, including Arizona, Florida, New York, and Washington. And in case of Arizona, they had to double their premiums from $17.50 per child to $35 per child.
Interesting. And did you notice the comments in the staff report and the recommendation in the agenda, and just the suggestion to look at alternative premium and co-payment, increased proposals, savings estimates for increasing?
We would be happy to develop estimates for your consultant.
We appreciate that very much. Thank you. Very good. We'll move to public comment. Mr. Valencia.
Good afternoon, Mr. Chairman. John Valencia, representing VSP Vision Plan. I'm accompanied by Lucinda Ward, Regional Manager for VSP, who will actually speak to what we hope will be any one of a number of alternatives that might be explored. My job is to share just a couple of quick facts about VSP's involvement with healthy families and why each one of the policy choices represents a direct fiscal impact for the state. VSP is organized as a not-for-profit health care plan in California. Our specialty is vision care. And while we cover 1 in 3 Californians and 1 in 6 Americans, for purposes of the committee, we cover 80% of the children in healthy families. That's over 700,000 kids in the program for their vision benefit. What's critical is that each step that you take is going to have an impact that'll have a downline result. It's important for kids to get vision care simply because of the following data. 80% of what a child learns is through their eyes. 1 in 4 school-age kids have some form of vision problem. We estimate, and we have concurrence in it, that something like only 14% of children have a comprehensive preventative eye exam and a plan for treatment. Uncorrected vision care obviously has a downline impact on what a child can learn. Children are difficult patients. They simply don't realize what they can't see because maturity hasn't set in. However, once they do obtain correction, once they get either lenses or some other corrective device, the child's learning and behavior improves significantly. That's measurable. And finally, there's a direct correlative with our endemic obesity and diabetes problem. Diabetic retinopathy is diagnosed most efficiently, very effectively, through preventative exams. When vision isn't examined, we have a real possibility of missing that. And according to the CDC, 2 in 10 people who develop diabetes will have missed the opportunity to have that diagnosed as a result of a preventative examination and treatment plan. With that, I'd like to turn over comments on options to Ms. Ward.
Thank you.
Thank you. I feel short. My name is Lucinda Ward. I'm a regional manager with VSP. I have been working with the Healthy Families Program and Mr. Mibb since prior to inception in 1988 to currently. I also handle the state of California annuitants, the Senate, and the Assembly VSP contracts. The proposal to eliminate the vision care puts the kids at even a higher risk. Putting them back into the medical plans, many of the plans today are looking at just screenings and not necessarily comprehensive eye exams. If there's a medical condition like pink eye or something detected, obviously the medical plan would be able to take care of that. But if the child needs vision care, or glasses or anything like that, that would not be part of that plan, which would be significant cost out of pocket to those parents. We do understand the fiscal situation that's going on right now in the state, with not only the state, but the cities and the counties and school districts and everybody. And so what I wanted to do is be able to provide some sort of proposal to have something in the middle, to have some middle ground versus losing vision altogether. And so today, the kids of Healthy Families pay a $5 copay and they get their eye exam. And then they pay a $5 copay and they get lenses covered in full and $75 towards a frame. That's a great plan. It's modeled after the state of California employee plan. But what we could do is look at other options. One of the options that we were considering and that we would propose for a savings is to have an eye exam with a copay as today. But instead of the more robust material plan is to have an allowance with discounts towards materials. So an allowance of, let's say, $75 towards materials with discounts applied from our VSP doctors. That plan would save the state, we estimate, and we do cover the bulk of the kids, is about $3.6 million in savings directly to the state to do an option such as that. We would like to, I handed out a little example, and you can look at that, but if for just the sake of the example, it just shows you what today the out-of-pocket would be, if they were to go to our proposed plan, what their out-of-pocket would be, and if they had no vision, what their out-of-pocket would be. So just for the sake of time. We respectfully ask the committee and the governor to seriously consider alternative options versus an all-or-nothing approach, kind of meeting in the middle ground. And we are partners. We've been partners with Mr. Mibb for a long time. We continue to partner with the state, and we will make sure that we do everything we can to work with you.
Thank you very much. We'll look at the proposal.
Carolyn Gino with the California Medical Association. California's physicians are opposed to the removal of the vision benefit for the Healthy Families beneficiaries, but also the proposed increases in the copays for the program. There have been 2 rounds of increases on this since the budget was completed last year in February and in November. And for a number of these beneficiaries, including that group between 151% and 200% of FPL, their premiums, if this proposal goes through, will have increased over 200% in a year's time. And given unemployment in the current economy, we're just really concerned about their ability to get this care and coverage. Thank you.
Thank you.
Mr. Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty, also very concerned about the proposal to increase premiums. Your consultant did a nice chart which shows you the increases that families have already had to subsume in the last year, and we're very concerned about effectively doubling those premiums for pretty low-income families. Just to give you an example, a single working mother who had 3 children, today, if she has a $34,000 annual income, she's spending about $500 today per year for her family, and that will double to over $1,000, which is a pretty hefty price for these low-income families. We also share the concerns about the elimination of vision coverage and the ability of children and low-income children to learn when they can't see. Thank you.
Thank you. Good afternoon.
Good afternoon again. Cliff Sarkin on behalf of the Children's Defense Fund and the 100% campaign. Quick points on both the premium increase and division. On premiums, just this week, a lot of us got a note from our insurer, Anthem Blue Cross, that our premiums are going up 39% for these kids and healthy families. This is an 88% increase over what they're currently paying. Just to let the committee know that in each of the last 2 budgets, we've increased their premiums as well. As far as vision goes, repeating a lot of what those that came before me mentioned, but more than a quarter of kids that are school age have some sort of vision issue. And I was just standing up here looking over the audience and looking at all of my bespectacled brethren, thinking how different our experience would be not being able to have glasses. And commending the governor on supporting higher education in this year's budget, but thinking what it would be like for a child to be in a classroom, in the back of the classroom, not being able to see the chalkboard. Again, very foolish decision to cut vision coverage, not allowing children the very cost-effective, cheap, in fact, investment of providing them vision care and glasses so they can be in classrooms ready to learn and growing up healthy and strong. And my final point, really encourage the committee not to see these 2 cuts as alternatives to the eligibility cut. All of them, in and of themselves, would be troubling and devastating for children in California. Thank you.
Thank you very much. You sure we still have blackboards in school? Chalkboards?
Or the PowerPoint.
Okay. Thank you.
Mr. Chairman, Terry McHale with Aaron Reed and Associates representing the California Optometric Association. And I would take the previous speaker's point one step further and note that 7 of the 9 people up on the front of this room were wearing glasses today. And if we were all to take our glasses off, just think of how difficult it would be for us just to accomplish our daily task. There's a wonderful story by Peggy Noonan in her biography of Ronald Reagan. And Ronald Reagan said he was in a car one day with classmates, and he grabbed one of his friend's glasses and put them on. And at that moment, his life changed. For the first time, he saw trees that had leaves. And so you stop and you think about children not having eye care. And it's very easy to understand what the previous speakers have said about the concomitant consequences of making that decision. So I hope you will listen to the staff, and let's find some solutions and make sure that our children can see their future. Thank you very much.
Thank you very much, Terry. That does conclude the public comment on this issue. Any comments from the committee? Seeing none, we'll move now to the Department of Health Care Services. And thank you for your participation today and being here from the department. And we will move issue 8 up to the beginning of this discussion, and that's the reduction of funding for CCS to conform to Healthy Families Program eligibility, reduction from 250 to 200% of the federal poverty level.
Good afternoon.
Good afternoon.
Mr.
Thanks
Chair,
for being
Vanessa
here.
Baird, Department of Health Care Services. I'm here to talk about the impact of the Healthy Families reduction in eligibility from 250 to 200% of federal poverty level that it will have on the California Children's Services Program, which is administered by the Department of Health Care Services. The California Children's Services Program, I will use the term CCS, provides care management and health care services related to a specific CCS-eligible condition that children under 21 who reside in California and meet financial eligibility criteria. The CCS program has a wide range of conditions that would qualify, such as diabetes, conditions associated with premature birth, cancer, hearing loss. There's a very long list of conditions. The families meet financial eligibility criteria through several means. They meet it through being on Medi-Cal. They meet it by being enrolled in the Healthy Families program. And then there is a state-only eligibility area where they qualify if they have adjusted gross incomes up to $40,000 per year, or if they can demonstrate that 20% or more of their income is associated with paying for the care of that child. Because of the Healthy Families reduction to 200% of federal poverty level, the department has estimated that approximately 556 children who are currently in Healthy Families and also are participating in the CCS program, after losing their Healthy Families eligibility, will then qualify for the state-only program. So the estimate shows that there would be an increased cost to the CCS state-only program, and it's reflected in the estimate for fiscal year 10-11 at a general fund cost of $1.1 billion.
Okay, thank you. Elios, you fine with this? Finance? No problem. Thank you. Public comment? Okay, thank you. Good afternoon.
Good afternoon. Ms. Hill, Ms. Bromley. Greg DeGier for the ARC of California, the state's largest organization speaking for people with intellectual and developmental disabilities and their families. Medi-Cal is the principal care payer for adults with intellectual and developmental disabilities in California, so any cuts will impact them disproportionately. The cuts that are being considered here will add to their existing problems with receiving adequate health care. And I'd just like to go over some of them. Their health care needs are complex. Medical equipment is often not accessible to them despite the requirements of the Americans with Disabilities Act. Their mobility is often very limited, making it difficult for them to even get to a doctor. And unfortunately, medical professionals often lack the training and experience necessary to treat them, and too often, even medical professionals have biased attitudes towards people with intellectual and developmental disabilities that make them reluctant to treat their diseases. Thanks to the Linerman Act, as you know, the people with intellectual and developmental disabilities are entitled to the supports they need, and the governor's budget does include backfill funds for the Department of Developmental Services for some of the proposed cuts in Medi-Cal and other programs. However, I emphasize some. In order to be eligible, the person has to get the service into their individual program plan, which has gotten increasingly difficult because of some of the trailer bill language that's adopted that's put obstacles in the way of people getting the services they need. And in addition, when there is a cut in some other program and people have to shift to the regional center system, there's often a delay of 2 or 3 months, during which time they have no services. So we are opposed to these cuts.
Thank you. That concludes the public comment, and I know on this particular recommendation we want to defer it to the regular budget process, and since this is tied so closely to Healthy Families proposal, the Healthy Families proposal, we want to address that first before we deal with this. So we'll move now to issue 1, which is the federal approval to establish limits of benefits, expand cost sharing, and other program changes. Mr. Douglas, good afternoon.
Good afternoon, Assemblymember Hill, members of the committee. Toby Douglas, Department of Health Care Services. The department has several proposed reductions within its budget. This is in addition to several proposals that attempt to receive additional federal funding from the federal government through extension of the fiscal stimulus, the ARA funding, as well as appropriate recalculation of the federal matching assistance rate, as well as receiving funds that should have been borne to Medicare that have been borne to the Medi-Cal program. These reductions are in areas of our budget where we continue to have authority given the federal constraints, such as the maintenance of effort issues around eligibility, as well as our injunctions on payment rates and injunctions as we've tried to tailor benefits. These are where we have options to control costs, but they definitely have significant impacts on our beneficiaries and providers. And the first one that we are proposing is to do cost containment within the program of $750 million general fund to try to become more in line with other state Medicaid programs throughout the nation by implementing more cost sharing through co-payments, mandatory co-payments, as well as mandatory premiums on higher income populations, using utilization controls such as hard caps on the number of services that are provided, as well as providing more flexibility on how we set our payment rates. So, any questions on that?
I guess the question is, will there be more detail provided?
We're working on the detail within the administration. We also plan to talk with various stakeholder groups about this proposal. Given the enormity of the budget situation, we believe we need to look at different approaches and looking at other states. As the write-up mentions, there are states like Texas that have done hard limits. Other states have done that, as well as co-payments, and discuss this with stakeholders. In the meantime, we're also working internally on the fiscal impacts of the various proposals.
Okay, so when will you have more detail?
We're hoping over the coming weeks to have more information.
All right, well, that's important, certainly, because of the special session nature of this, number one, and obviously for the long-term discussion of the issue, so thank you. LAO's office, response, please.
Good afternoon, members. I'm Meredith Worden with the Legislative Analyst's Office. We believe the administration's approach has merit and that the level of savings may be achievable. However, we are withholding our recommendation at this time until a more detailed proposal is put forth.
Very good, thank you. Finance?
John Wunderlich with the Department of Finance. No additional comments to what the department has said at this time.
Very good, thank you very much. We'll now move to public comment. Good afternoon again.
Good afternoon, Mr. Chair and members. Elizabeth Landsberg with the Western Center on Law and Poverty. And while we recognize that this hearing today is focused on the special session cuts, we do think it important to view the cuts to Medi-Cal in their entirety, and there are some very extreme cuts proposed to Medi-Cal, particularly in the trigger cuts. We also think it's important, of course, this committee is painfully aware of the cuts the Medi-Cal population has already sustained, in particular the benefit, dental, podiatry, and other cuts last year. As to this specific cost containment proposal, it's difficult to comment. We have had a chance to review the trailer bill language, and effectively the department is asking this committee to grant it carte blanche authority to do almost anything within the program within the confines of federal law, to change the amount that beneficiaries have to pay for services, to change the types and number of benefits people can get. So it's really difficult to assess it. It's reminiscent of the committee hearing last week where the full budget committee said, no, we're not going to give blanket authority for deferrals. This similarly is asking the department to do whatever they want, and we would certainly urge the committee to wait until there are specifics, and we look forward to the opportunity to review those specifics when they are available. Thank you.
Great. Thank you very much.
Thank you, Mr. Chair, members of the committee. Carolyn Gino with the California Medical Association. I agree with the comments of Ms. Landsberg before me. We are, of course, very concerned and would hope that California's physicians would have a seat at any table for a stakeholder group to discuss fleshing out this proposal. Appreciate your commentary on the lack of substance in it at this point. And, of course, we're very concerned about some of the elements of it. Utilization controls that can limit necessary care being delivered to beneficiaries, any increased cost sharing that can price out some of these needy Californians from the care that they need, and other elements as well. So thank you for your comments again, sir, and we'll look forward to seeing what's in the proposal.
Thank you.
Chairman and members, Barbara Glazer with the California Hospital Association, and also today on behalf of the California Association of Public Hospitals and our Disproportionate Share Hospital Task Force, we are very concerned about this cost containment proposal. As has been stated, it lacks specificity. Until we understand it and know its real impact on the people we serve, we would hope that you would not take action on it. I also want to point out that it does, the proposal will save the general fund $750 million, but keep in mind in total funds it's well over $2 billion. That's a lot of money to take out of the Medi-Cal program, and we are very concerned about it.
Thank you.
Mr. Chairman and members, Nathan Mansky representing the Private Essential Access Community Hospitals, or PEACH. PEACH is, in fact, happens to be a member of the DISH task force that Ms. Glazer mentioned, so I won't repeat her comments. I'll just say that we certainly concur in recommending to the committee a go slow approach until more detail is known about this proposal. Thank you.
Thank you.
Mr. Chair and members, Terry Calgar-Hill on behalf of the Hemophilia Council of California, representing the 4,000 people with hemophilia and other bleeding disorders. We, too, strongly object to this broad proposal with few details. The trailer bill language gives the department extensive authority to make the $2 billion in cuts, and it troubles us, particularly with patients with hemophilia. The current protocol is to self-infuse or to infuse on a regular basis several times per week. That's to keep the blood flowing properly so that they don't have bleeds into their joints, so they don't have severe and crippling arthritis, and so they don't end up in the emergency room or getting episodic care in those types of settings. So we think that we need to look at this very carefully. Decisions of medical care should be handled with the physicians, the hematologists, and the patients, and we don't want to get into the in that type of business. So we would say proceed with caution and reject this proposal today.
Thank you.
Good afternoon, Margaret Johnson with Disability Rights California. We too are concerned about the proposed cuts to services and increases to copays because we believe that might deny many seniors and people with disabilities access to health care, and it could put Medi-Cal out of their financial reach. Inevitably, this would result in declines in overall health, an increase in costly emergency room visits, and people potentially being forced into institutions because they would not have any other means to access health care services. Thank you.
Thank you, Margaret.
Mr. Chairman and members of the committee, Jessica Rothar with Health Access California. We wish to associate ourselves with the remarks of those who have gone before in opposition to these cuts and the increase in out-of-pocket costs for people on Medi-Cal. I have spent 8 years taking calls from consumers on Medi-Cal. I've never yet spoken to one who was getting rich. They don't have any more money to spend on copays and out-of-pocket costs, and we're particularly concerned about the possibility of increased utilization controls in a program that's already struggling to meet the needs of those who are lucky enough to have the coverage. Thank you.
Thank you.
Good afternoon, Chair and members. Serena Kirk from the California Primary Care Association, representing the community clinics of the state. Definitely want to echo many of the concerns already voiced today, over the lack of specifics included in this proposal, but certainly want to oppose any reductions to Medi-Cal. Our community clinics already operate on very lean budgets, and especially after, enduring many of the reductions of last year's budget, specifically the elimination of Medi-Cal optional benefits has really, put a lot of limitations on their ability to provide care. The Medi-Cal program is absolutely the bread and butter for many of our clinics. For some of them, it's 50 to 80% of their revenue in their ability to provide care for all patients, not just their Medi-Cal patients. So while there's not a whole lot of details, so it's hard for us to do an analysis on exactly how this would impact the clinics, we certainly want to oppose this proposal.
Thank you, Mr. Chair. Members, Nick Luizos again with the California Association of Health Plans. We share the concern that other organizations do about the lack of specificity with this particular proposal. Again, we understand that the state is in a difficult spot this year with the budget. However, to the extent that there are discussions and the proposals impact the Medi-Cal Managed Care Program, our members would be interested in being part of any discussions. Thank you.
Thank you. Good afternoon.
Missy Johnson with the California Retailers Association, representing approximately 3,500 chain drug stores across the state. We also share the concerns that were echoed by many of the other previous speakers. We understand that the proposal is forthcoming. We look forward to working with the department on those.
Thank you.
Good afternoon. Mario Guerrero with the California Lesbian, Gay, Bisexual, and Transgender Health and Human Services Network, a project of Equality California Institute. Data from the California Health Interview Survey suggests that as many as 11.8% of LGBT, lesbian, gay, bisexual people in California receive Medi-Cal. The governor's proposal to find savings by increasing cost sharing for Medi-Cal beneficiaries will result in even higher insurance rates for the LGBT people. We already have high rates of uninsurance. Data from other reports also suggest that transgender people face even higher rates of uninsurance, making Medi-Cal even more essential to prevent costly care for this vulnerable population. We also look forward to hearing more information, but oppose any cuts. Thank you.
Thank you.
Hi, Michael Martinez here on behalf of Ultimed, and agree with many of the comments that have been stated before. Certainly look forward to receiving more detailed specifics. Secondly, should and if there be any further stakeholder discussions, be a part of those as well. And then thirdly, just with regard to the actual proposed draft trailer bill language, we hope that should and if the subcommittees decide to go down this road, that we have further legislative involvement and oversight on anything that moves forward in this with regard to this proposal. Thank you.
Wonderful. Thank you. That ends the public comment for this item. And Mr. Douglas, in terms of the stakeholders, and Mr. Martinez mentioned that, are you planning to have any stakeholder meetings?
We're reaching out, right? We'll be reaching out in the next couple of days to different associations to talk about the various proposals.
Wonderful. That's great. Thank you very much. Oh, 2 and 3. Mr. Douglas, you'll be presenting the items, the next two items, 2 and 3? Oh, great. Well, why don't we do the two together, issue 2 and 3, at the same time? Then we can have the public after that. So it'd be great. Thank you.
Thank you, Mr. Chair. The Department is proposing to eliminate full-scope Medi-Cal for newly qualified aliens. These are individuals who are legal permanent residents, but they are subject to a 5-year waiting period before the federal government will provide a match for any services other than emergency and pregnancy-related services. We are exempting pregnant women and children from this reduction because we're exercising our option under the Children's Health Insurance Program Reauthorization Act of 2009 that allows us to claim a federal match for full-scope benefits. The affected individuals will still continue to have emergency-related services and that for which we can get a federal match, and they will also still have access to long-term care services, the breast and cervical cancer treatment program, and TB treatment at a state-only expense. This proposal will result in modest general fund savings in the current year of less than $700,000 and $54 million in the budget year. The second category is very similar to the proposal for the newly qualified aliens, where we are proposing to eliminate full-scope benefits for the PRUCAL immigrants, persons residing under the color of law. This is no longer a federal immigration category, but we have continued to provide full-scope benefits at state expense for this population. We will continue to provide emergency-related services and pregnancy-related services, and the long-term care, breast and cervical cancer treatment, and TB services. This proposal will save $465,000 general fund in the current year and $64 million in the budget year.
Very good. Thank you. Let's hear the LEO's response to that first. And then we'll
Thank you, Mr. Chair and members. Farah Brock with the Legislative Analyst's Office. We are recommending that the legislature adopt the governor's proposals to eliminate the full-scope benefits for these immigrants. This is because of the state's fiscal condition and the lack of federal matching funds for these services.
Thank you. Finance?
Just one general comment that pertains to a number of the issues on the agenda, and that is just as we delay in taking some of these actions, the savings numbers that have been quoted would erode, and so there would be less savings available in the budget year.
Doesn't this seem to be the same issue that we've been talking about? I mean, the 65,000 people that we're discussing, I mean, they're going to need care somewhere, and again, it's going to fall down to the counties to provide that in one form or another. So it looks like we're just pushing it and shifting that cost again. Did you have a response to that, Mr. Novy?
Assemblymember held that in some instances that is true. It's either going to be these individuals will have to be paying out of pocket for the services, or to the extent that counties do cover them under their medically indigent programs, that it would be a cost shift to the counties.
Thank you. We'll move to public comment.
Good afternoon, Mr. Chair and members. Vanessa Kahina with the California Immigrant Policy Center, also representing the Asian Pacific American Legal Center of Southern California, Services Immigrant Rights and Education Network of San Jose, the National Immigration Law Center, and the Coalition for Humane Immigrant Rights of Los Angeles. We are here today once again to oppose the governor's proposed cuts and elimination of full-scope Medi-Cal services to newly qualified legal immigrants as well as PRU-call immigrants. We believe these cuts are prejudicial and will result in a cost shift to an already overburdened hospital care system, as well as a loss of quality of life and quite possibly a loss of life to those pushed into emergency care. As to the newly qualified immigrants, these are green card holders who have lived in the United States for fewer than 5 years but can't afford or qualify for private health insurance. This also includes elderly and disabled immigrants and seniors with manageable conditions that would escalate dangerously without routine, inexpensive care like high blood pressure and arthritis. As to the PRU calls, as the Department of Healthcare Services did correctly state, this is not an immigration category. However, it is a benefit category. It stands for permanently residing under color of law. It means that the government is fully aware of their presence in the country, has no intentions to deport them. This includes some pretty special populations, as your staff analysis pointed out, including domestic violence survivors and victims of serious crimes, including spouses and children of U.S. citizens who have applied for their LPR status, including abused or neglected children in the foster care system, including other individuals who have been granted permission to live or work in the United States. As such, we oppose these proposals and are happy to provide you with any more information and appreciate your comments as to how many times you've rejected these before. Thank you.
Thank you.
Hi, my name is Carrie Sanders, again on behalf of the California Pan-Ethnic Health Network and also representing the Having Our Say Coalition. And we urge you to reject this, the governor's proposal to deny Medi-Cal for lawfully residing immigrants. This will only result in even greater health disparities for the communities that we serve. Cutting benefits for 68,000 low-income residents is also short-sighted and inhumane. Many of these recipients have health conditions that are routine and easily manageable, but cutting their benefits will turn routine conditions into emergencies and will only cost the state more in the long term. I'd like to cede the rest of my time to two of our members of our coalition, the Having Our Say Coalition, Art Choi from the Korean Community Center in the East Bay of Oakland, and Noe Paramo from Central Valley Partnership in Modesto, who can speak more specifically to the impact of these cuts.
Thank you. Good afternoon.
Good afternoon. My name is Art Choi, and I'm the program manager for the Korean Community Center of the East Bay in Oakland, and I'm here to share our concerns about the governor's proposed budget cuts to Medi-Cal. Our organization serves more than 400 new clients per year, mostly low-income Korean seniors, but not limited to other communities of color, who have recently immigrated to the United States. Many of our clients do not speak English very well and find it very difficult to navigate the United States healthcare system. Their health issues range from high cholesterol levels to life-threatening illnesses such as heart disease and diabetes. The Medi-Cal program is critical in helping these recently arrived immigrants to get the health care they need, including preventative care. The government's proposal to deny Medi-Cal for thousands of lawfully residing immigrants will make it much more difficult for our clients to treat ordinary health conditions before they turn into emergencies. And without the full scope Medi-Cal, our clients will end up having to rely on more expensive emergency care for illnesses that could have been prevented. And I know you've been hearing lots of stories, so for a brief example, I work with many clients such as Mrs. Park, and she's a senior over 65, and she lives in a senior housing facility. She has no family that is nearby and no means of accessing resources. If full scope Medi-Cal was denied to her, she will not have the medication and treatment she needs to simply survive on a daily basis. Without Medi-Cal, she'll be forced to go to emergency rooms or local hospitals that will charge her hundreds and thousands of dollars per visit just to receive medication and treatment. And Mrs. Parkin is in a stable health condition comparable to any other elderly person receiving Medi-Cal. Her conditions are easily managed with routine care and with a physician who can communicate with her. So if full-scale Medi-Cal was denied, again, it is preventing my clients and Mrs. Park to prevent their health problems to live a healthy life. So we urge you to reject the governor's proposal to cut this valuable program. So thank you for your time and consideration.
Thank you, Mr. Choi.
Mr. Chair, members of the committee, Noé Paramo. I'm with the Central Valley Partnership for Citizenship, and we promote civic participation for immigrant, migrant, farm worker, rural communities in California Central Valley. And I stand with my colleagues before me, the three who spoke, in that we oppose these cuts. Our communities are looking to participate in the daily life of their families and their children so that they have good quality of life and continue to participate in the decisions that are going to impact these lives. Our communities in the Central Valley, Modesto, Merced, Fresno, Bakersfield, are reeling from the high unemployment, home foreclosures, and high poverty rates. You go to these schools, 60% of these children are poverty, and they're under lunch programs, and the schools are having a hard time, families are having a hard time, and now you're going to go and do something else to take these safety net programs away from these communities. I urge you to stand and oppose these cuts and respect our communities, allow them to live in dignity, and allow them the opportunity to have a quality of life and participate in California. Thank you very much.
Mr. Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty. Associate myself with the earlier comments, also here in opposition to this cut. I want to be clear, if this cut is made, folks just will go without services. First of all, the county programs don't provide the same level of services as Medi-Cal. Different counties have different rules, and many of them have their own immigration requirements. So we can't pretend that these folks are going to be able to get services elsewhere. This legislature has time and again made the right choice to provide full-scope Medi-Cal to these legal immigrants who pay taxes. We encourage you to continue. Thank you very much.
Thank you.
Jessica Rothar, Health Access California. We associate ourselves with the previous remarks and ask you to oppose these cuts. Another point I would just want to add is that as the entire nation looks to improving health behaviors and the take-up of primary and preventive care, these are legal immigrants, lawfully residing immigrants. They're going to be here for the rest of their lives. This is not the time to change the message about the importance of participating in regular primary and preventive care. Thank you.
Thank you.
Good afternoon, Serena Kirk, California Primary Care Association. Obviously want to urge you to consider the impact specifically on this population. And additionally, our community clinics are essentially providers of care for every single healthcare program that has been slated for reduction or elimination within the governor's proposal. So this reduction would just be an additional hit on our clinics of millions of dollars in losses. And speaking to Assemblymember Hill's comment about the shifting of costs and the fact that these patients will need to seek care somewhere, and it sounds as if there will be some county limitations. Our community clinics will be the providers of care for many of these populations. Many of our federally qualified health centers are required by law to provide care for anyone who walks through their doors, regardless of their ability to pay, et cetera. So for clinics that are already overburdened, we really feel like this would be a further impact on their ability to provide care. Of note, last year, due to the budget cuts, we've actually in the last 5 months seen 5 clinics close statewide. This is a loss of hundreds of thousands of patients losing access to care. Additionally, currently we have 11 more clinics, mostly in rural areas, that are on the brink of closure as well. So we urge you to consider these things when making these cuts. Thank you.
Thank you.
Good afternoon, Mr. Chair and members. Santosh Sriram Santana with Asian Americans for Civil Rights and Equality, and we oppose the governor's proposal to eliminate full-scope Medi-Cal for current legal immigrants, newly qualified legal immigrants, for all of the reasons previously stated by my colleagues. Thank you.
Thank you.
Judith Riegel with the County Health Executives Association. We are really concerned about the impact of these cuts on our county health systems, our clinics and hospitals that are already seeing huge surges in demand from the uninsured due to the recession. Thank you.
Thank you very much.
Good afternoon, Mr. Chair, members of the committee. Mario Guerrero with the California Lesbian, Gay, Bisexual, Transgender Health and Human Services Network, Project of Equality, California. LGBT people sometimes immigrate legally to the United States because they face profound discrimination, stigma, and persecution in their countries of origin. The governor's proposal targets lawful immigrants, including those who have had legal permanent status for fewer than 5 years, restricting their Medi-Cal benefits to emergency only. Cutting these benefits to the LGBT immigrants who may have physical or emotional disabilities will cost the state more money in the long term as people get sicker and end up in the emergency room. We urge you to oppose these cuts. Thank you.
Michael Martinez here on behalf of Ultimate Health Services. It is actually the state's largest FQHC based in Los Angeles and Orange counties. And to CPCA's comments, indeed, we do see individuals who walk through our doors regardless of their ability to pay. And Ultimate serves primarily the Latino community in LA and Orange counties, and we believe both of these proposals will have a very awful effect on that community. And the legislature was very wise to reject these proposals in past budget proposals by the governor's office, and we ask for you to do so again. Thank you.
Very good. Thank you very much. And we'll bring it back to the committee. And Mr. Bell, you had some questions related to issue 1. Is that true? Or comments? I know you were out for a moment.
Yeah, we had mandated training, and they schedule it
at the worst time.
I think it's a good thing to do, but I think I wish they'd schedule it at other times. This is relative to the Medi-Cal waiver. I have prepared a letter to David Maxwell Jolly, and it basically reflects my comments on the waiver and what kind of things I think ought to be considered in terms of the agreement with the federal government. I have a list of items that I would like to see in the waiver. I don't need to go over them right now, Mr. Chairman, but suffice to say, I would like to have these lists of items included in the discussions for the waiver and have them examined by the staff and the LAO for discussion.
Very good.
And I think one of the jobs of this committee would be to oversight the waiver that's being negotiated right now. There's a stakeholder group. People are involved in that. I have specific things that I would like to see in the waiver. I think it's something that we need to have maybe a fuller discussion as committee on in terms of what is the breadth and scope and changes that are being discussed, and whether or not the legislature agrees with those, or what direction the legislature would like to go in terms of the waiver. My letter will be, I'd like to turn my letter in to you right now and then pass it out for the committee's consideration.
Great. Thank you, Mr. Bell.
Thank you.
And I did want to indicate that Assemblymember Chesbro has joined us again today, and we really appreciate your attendance and participation. We'll now move on to the next issue 4, the elimination of adult day health care. Good afternoon.
Good afternoon, Barbara Bailey, Department of Healthcare Services. As your committee agenda describes, the governor's budget proposes elimination of adult day health care, or ADHC, as a Medi-Cal benefit, which would save $1.5 million general fund in current year and $134 million general fund in budget year. In California, ADHC is a program of health and social services provided to approximately 55,000 eligible Medi-Cal beneficiaries annually. ADHC is an optional Medicaid benefit, meaning that states are not federally mandated to provide these services to Medicaid beneficiaries. California is one of only 8 states in the nation to provide ADHC as a Medicaid benefit.
Very good, thank you. I know there is a question that was raised, and perhaps maybe we'll let the LAO talk about this, but a year ago, I guess there was a concern that if 20% of the ADHD consumers enter a skilled nursing facility, there would be a greater cost to the system and to the state as a result of the elimination. So what, and the high cost, is that the same percentage that you're looking at this year? And if that is the case, then where is the savings? And that would be to both.
Thank you, Mr.
Thank you.
Chair. I'm Meredith Worden with the Legislative Analyst's Office. Our recommendation in May last year was we recommended against the legislature adopting the governor's proposal to eliminate adult daily health care and instead proposed an alternative approach to target services to those who are at most risk for institutionalization, and in addition capping the program. We note, however, that this type of proposal would likely require a federal waiver and as such would limit the state's ability to achieve savings quickly as they take a while to negotiate. This is something that the legislature may still wish to pursue. This year we are recommending that the legislature adopt the governor's proposal due to the state's fiscal situation and need for immediate savings. However, our understanding is that a reasonable argument could be made that the elimination of the ADHD benefit conflicts with the Americans with Disabilities Act.
Thank you.
Thus, the state would need a plan in place if it chooses to close the ADHD benefit to shift beneficiaries to other community-based services where they are available. And we are further recommending that the legislature direct the administration to develop a savings estimate that incorporates administrative savings as well as potential cost shifts to other services. With regard to the 20% number that you referenced, this was provided as an illustration to demonstrate kind of how at what level of beneficiaries would have to shift into a skilled nursing facility to completely offset what we spend on ADHD services. This would assume an immediate cost shift. That particular analysis does not consider several key factors such as cost shifts to other services, and that other these beneficiaries also utilize other community-based services, and that analysis also does not consider the length of time between being on a ADHD community service benefit relative to the length of stay in a nursing home facility.
So I guess, Mr. Douglas, the question arises, how, I mean, where's the savings? Is there going to be a savings related to this, the elimination of this program? And has there been and it looks like it's in the process of some cost-benefit analysis related to that. And we had the similar problem yesterday when we were discussing the IHSS program, and what we heard from that program was that there really hasn't been a comprehensive analysis of the cost-benefit. And so, to me, it looked like a gamble. And so I'm just wondering if that has been done with regards to this.
Good question. I mean, first of all, I do want to make it clear, as I said at the beginning, there are going to be impacts, and we do expect that over time that there will be cost shifts. The issue that we face as an administration is there's uncertainty on the timing, the magnitude of those cost shifts, and at this point, we elected to not show any cost shifts in the savings amount. There has never been an analysis of how beneficiaries would move because there's so much uncertainty on how the movement would occur. Individuals who are in an ADHD are not all at a nursing facility level of care, and even if they are, the question would be, would they move into a nursing facility, or would it put an increased burden on their family or their extended household? There are impacts everywhere. It's how to quantify them. It's very difficult, and so the answer is we don't have a cost benefit, and unfortunately we wouldn't be able to do it. We do think there are savings here. There are savings and impacts that are some that are costs and others that are unquantifiable.
Okay, so what you're saying is that you really don't know what percentage would shift. And now, with regards to the LAO's analysis of this, you haven't done a detailed cost-benefit analysis of this particular shift. And is there a reason for that? Is it something you can do? And are you in the process of maybe trying to extrapolate something from what you have so that we can make a valued decision?
Thank you, Mr. Chair. A rigorous cost-benefit analysis usually compares the costs and benefits of various alternatives to determine if there is a net fiscal impact. And this can be helpful for your budget deliberations and would need to be informed by a comprehensive and reliable data. At this point, there are significant data limitations to do that analysis. We have requested from the department information on the potential cost shifts to other services and such as the utilization levels of ADHD beneficiaries at the ADHD service, as well as other programs such as IHSS. And even if more complete data were available, such a cost-benefit analysis would also have to include a number of assumptions that a reasonable person could arrive at a different conclusion about what assumptions should be made. And finally, we caution the legislature to completely rely on a cost-benefit analysis in order to make such decisions. And that you would likely like to weigh other impacts that are difficult to quantify, such as the quality of life to these beneficiaries.
Well, and I appreciate the answer. Just what comes to mind is, and I see the difficulty in arriving at the basic facts to do the analysis. However, it's difficult to do it sometimes, but I'm always amazed at the success and the great work that the LAO's office does in making assumptions related to future projections out years in advance that we rely on to make policy decisions in this legislature. So I would hope that we could come up with some assistance in that regard as we move forward with this discussion. So thank you. Yeah, we have a number of speakers, as you can see, which is great, and I know we're all very concerned about this program and the recommendation. We did, and we'll limit this to 2 minutes, but if you can be brief, for ditto works as well, if you want to do that one and two. So we're just looking to try and make sure that everyone has an opportunity to be heard today. So if you can be as brief as possible, we'd sure appreciate it. But we do want to make sure you do have that opportunity. So please, begin.
Good afternoon, Mr. Chair, members. Thank you for this opportunity. There are a number of people here to testify on this issue because of the emergency session and the possibility that there may not be another opportunity to testify again on this issue. So we do appreciate this opportunity. And members of the public and providers are here, each with a different point to make for you. So we did organize our testimony. I just wanted to clarify a couple of things that were already stated in the prior testimony. One is that adult day health care is offered in every state in the country. There are only actually 10 states, so 1/5 of the states offer it as an optional state plan benefit. Those states are the ones who were innovators in the late 1970s in designing alternatives to nursing home care as a result of the horror stories that were becoming very public of the state of affairs in nursing homes back in the 1970s. So California was once a leader in providing alternatives to institutional care. This program has evolved over 30 years. We not only prevent institutionalization or delay institutionalization, and there is some significant savings to be found when you delay institutionalization for a person with Alzheimer's, for example. A lot of studies on that. I don't have the numbers right in front of me. But we also serve as a preventive service. As you heard earlier in the afternoon about the elimination or the reduction of eligibility in the Healthy Families Program and the impact that has on children. We're the other end of that spectrum. And we prevent unnecessary hospitalizations, unnecessary 911 calls, unnecessary emergency calls. And you'll hear how that is done by others who actually do this work on the ground. I do have a handout for you. Some of you may have seen it already, and I also have an article from the LA Times, if the sergeant could please distribute this. So the fact sheet, I'm just going to highlight a couple of things and and move on. I do want to remind you, as your agenda states, that you rejected the elimination proposal last year. Instead, some new eligibility criteria were put into place that are going to take effect on March 1. Those new criteria are in addition to already tightened criteria that Mr. Chespro in his legislation, SB 1755, put into play beginning in 2008. So barely has there been enough time for the ink to dry on the new criteria from 2008, Mr. Chespro's bill, then we're now faced with additional criteria that stakeholders had no input into developing. Right. That is the subject of litigation in a federal court and should be decided by the end of this month, again, under the Americans with Disabilities Act.
I'm going to have to ask you to conclude, please.
Thank you. And the fact sheet does give you the survey data that we have received directly from people on the ground. It does indicate to you the job loss, the cost shift information, and I just want to remind you, if the program is eliminated, virtually every single center in your districts will close down. There will be no adult day health care left today or in the future. Thank you.
Thank you. We're off to a bad start on the timing, so no, thank you for your comments.
Good afternoon, Assembly Chair and members. My name is Nina Nalcox. I'm a registered nurse and public health nurse at Graceful Senescence Adult Day Health Care in South Los Angeles, where the health disparity is comparable to that of a third world country. I've worked in various settings. I started out in skilled nursing facilities, acute care, critical care, home health, and finally adult day health care, which was the first place that I had ever worked where I was actually able to implement interventions to prevent hospitalization and higher cost care. I want to give you a sample of one participant that is guaranteed to result in increased cost and to shift to higher cost care. This is a young man that's in his 40s. His primary caregiver is his 78-year-old grandmother. He has type 1 diabetes and has blood glucose levels that run from the 30s to the 700s when we got him. His grandmother was activating EMS no less than 2 to 4 times a month. So she would dial 911 when his blood glucose levels would drop. They would transport him to the emergency room where they would work him up, and the same thing for an elevated blood glucose level. As a result of work coming to adult day health care, we have successfully worked with the diabetic clinic to get his blood glucose levels under control. We have licensed nurses there that when his blood glucose levels drop, we actually provide interventions so that we don't have to activate EMS. We also, if they're high, we can administer insulin and not activate EMS. Actually, as a result of this, in the last 6 months, he's only required 1 EMS call. Adult day health care is probably one of the most dynamic health care programs that I've worked in the various settings. I am appalled every time that I see it's up for some type of elimination. I would ask that you please reject this proposal.
Thank you very much. I did want to remind everyone that we are on call to go back into session in the Assembly, and that may come at any time. And if it does, we'll have to recess until we reconvene. So I just let you know that if that happens, you may be standing there. So just as another encouragement to unless we're stuck and halfway through. So I'd like to finish this item if we can. Please.
Good afternoon, committee members. My name is Dr. Sherry Anselmi. I'm the director at Elder Day. It's an adult day health care center in Santa Cruz, California. We serve 136 individuals, and we're the only adult day health care center from Santa Maria to Half Moon Bay on the Central Coast. So I'm going to tell you about Pedro. Pedro's about so high. He's 87 years old, thinning hair, kind of hunches over, talks to his teeth a little bit like this, and he shuffles a lot. Pedro's been diagnosed with severe Alzheimer's. He can't feed himself. He can't toilet himself. He can't do much of anything without the help of our staff. Because of Elder Day, he's fed, he's safe, he's clean, and most importantly, his caregivers can work outside the home. So some of you might be thinking, oh, well, Santa Cruz, you know, they're liberal, peace-loving, all that kind of stuff. You must have plenty of resources. You kind of people like this kind of stuff. Let me tell you what we don't have anymore in Santa Cruz. Alzheimer daycare resource centers, cut. Linkages, completely cut. Meals on Wheels for homeward bound seniors, cut. Caregiver resource centers, 70% cut. Oh, but you know what? We have the multi-service senior program, MSSP, so he'll get one phone call a month and one visit a quarter. These are slim pickings for somebody like Pedro. His options, skilled nursing facilities, more visits to the ER, and more visits to his primary care physician. Elimination of adult day health care centers is false cost savings. Thank you.
Thank you. We were just informed that at 3 o'clock we will be going back into session. That's 10 minutes from now. We will take a recess at 3 o'clock, and hopefully we'll be finished with this issue. Go ahead, sir.
I'll be quick. Good afternoon. My name is Paul Barrett. I'm a caregiver and volunteer advocacy advocate for the Alzheimer's Association. My wife Diana has younger onset Alzheimer's disease and is in the advanced stages. She was diagnosed at age 56 2.5 years ago. When she was age 60, I had to place her in an assisted living facility. For over 3 years, I was her sole caregiver. There finally came a time when I realized I could no longer do it alone. The time required to take care of her was beginning to overwhelm me, especially when it became evident that I could no longer leave her alone and that taking her with me everywhere was too difficult as well. I needed a break. I was told about an adult day health care center in Berkeley, the Alzheimer's services of the East Bay. I started taking Diana there about 3 days a week for 4 to 6 hours each of those days. I cannot begin to tell you what a tremendous relief it was for me to be able to escape the rigors of caregiving for just those few hours each week. And it was a relief to know how well she was being cared for. I would often observe while she was there, and the staff was very caring and paid close attention, watching for any problems that might arise, medical or otherwise. Please do not reduce the funding for the adult day health care centers.
Thank you. Good afternoon.
Good afternoon, Mr. Chairman, members of the committee. My name is Peter Baer. My father, also named Peter Baer, was a state senator a number of years ago. When he was a state senator, a Republican, one of his statements was that one of the obligations of government is to take care of the aged, the blind, and the disabled, those who cannot care for themselves. The people who come to the Guardian Adult Day Health Center, which I run, are mostly people who worked all of their lives. They committed, in the governor's eyes, one cardinal sin: they got old and feeble. We take care of West Contra Costa County, which is highly minority. Most of the people are poor. Most of the people who come to us live below the poverty line. These people paid taxes all their lives, which covered other people's services. Now the governor wants to say, oh, you don't have to have services. You can go slide under the bus. I'm sorry, that makes me angry. Adult day health centers prevent people from going into nursing homes. That's the reason I believe the program was started. I have heard an estimate as high as 60% of people in adult day health. Actually, that was an estimate, I believe, by somebody from the state back in the 1990s. I haven't seen any subsequent studies. Would be in nursing homes within 6 months if they didn't come. Based on the people in my center, that is probably true. Now, the governor says we're going to save a lot of money by shutting adult day health, but nobody seems to be able to support that proposition. There's a reason they can't support that proposition. It's just flat, blindly wrong. In addition to the shift of costs to nursing homes, which would overwhelm the savings very quickly, we're also talking about throwing a number of people onto the unemployment rolls who work in adult day health. We're also talking about many of the caregivers of the people who don't end up in nursing homes having to leave their jobs to take care of mom or dad. Currently, we watch mom or dad so they can go work. This is not a good idea. The savings aren't real. The only excuse for doing it is to save a lot of money, and nobody seems to be able to support the proposition that that's going to happen.
Sir,
it's a horrible idea.
Please
I recommend you to reject the governor's proposal.
Thank you.
Hello, Cass Sylvia. I'm the Yolo County elected public guardian. I know a lot about adult day health. I rely on it for some of our clients. It is so important that these folks who cannot be medication compliant themselves receive the help during the day, that they get fed, they get washed, they get all sorts of services that are on the skilled nursing level, but they don't live at skilled nursing, they live at home. It is so important. To cut this would be penny foolish, pound foolish, and people foolish. Thank you.
Thank you.
Good afternoon. Tracy McLeod. I'm the Program Director for Institute on Aging's Adult Day Healthcare in San Francisco. We recently did a survey in San Francisco through the 8 nonprofit centers we have there, and easily 13 to 15% of our participants would go to nursing facilities within 30 days of programs closing. That's about 140 people. Within 6 months, that rises to 40%, or about 365 people. While the cost shift is obvious, there is another really huge problem. There are not 365 available Medi-Cal beds in San Francisco. There aren't 140. There are none. San Francisco residents would have to leave our county, leave their families and their other supports. These are people that chose to remain living in the community. They need the skilled services to remain in the community, and yet we would be forcing them into care out of community. If they don't get into a nursing home bed, the option is to go through the emergency room and wait in acute care hospital until a bed becomes available. Finally, San Francisco is a county that takes the Olmsted decision very seriously. Adult day healthcare staff work very closely with nursing homes in our city, like Laguna Honda Hospital, to safely transition people out of nursing homes back into the community. Again, these are people that need that safety net. They require the skilled services provided by adult day health care centers. If adult day health care is eliminated, they are at a very high risk of going back into the institutions that they have a right to come out of per the Olmsted decision. Please reject the elimination of adult day health. Thank you.
Thank you.
I have handouts.
Thank you.
Good afternoon. My name is Kelly Folk. I'm the Chief Executive Officer for the Glenner Alzheimer's Family Centers. We operate 2 adult day health care centers and 1 social day program in San Diego. Thank you for the opportunity to come to you and talk to you about the elimination of 327 adult day health care centers in our state, which will also impact approximately 37,000 individuals. I'd like to talk to you about the roller coaster ride that our families have been on for the last 2 years. First, they've gone through the proposed elimination of adult day health care in 2009. Second, they were offered a 3-day cap, which impacted many of our families who attend 5 days a week, who need to be there 5 days a week. And this severe reduction in services would not be beneficial to them. Third, we were eliminated as an adult day care resource center, something we had been for 20 years. And fourth, now we're back up again with the elimination of adult day health care, and we know this is not an option. The assault on the developmentally disabled, the seniors and memory impaired who are served by ADHC programs has been continual. First and foremost, our individuals served by ADHCs fear that they'll be institutionalized, and the great strides that they have made through these programs will be all for none. Second, the families who care for these individuals wonder how they're going to provide the care that ADHCs provide. How are they going to pay for continued cost if ADHCs aren't here? And how are they going to work and care for this individual? ADHC works, and it provides the needed medical care to each individual we serve, ensuring they continue to function at the highest level and are out of institutional care. I would just ask you to remember, as you review this proposal for cost effectiveness, that you also remember the human cost that is associated with this. We all today represent everyone who can't speak on their own behalf as the human cost. Thank you so much for your time today.
Thank you. Welcome.
Hello, committee. I'm Robert Fitch's lifetime diabetes. I would have leaned forward. I'm sorry about that. Lived in California all my life in cerebral palsy. I also worked with Monty Emoto from CDCAN. But last 2 months, I've been going to the Rancho Cordova Adult Day Center, and it's given for time in decades. I've had physical therapy and speech therapy, so I can easier to get out of the tub and easier to talk. I'm also a social worker, and I've noticed several ethnic groups be able to talk among themselves and study, and I can tell that a lot of people couldn't live by themselves all day. So like someone else said, I wonder how many people would have to give up jobs and give up paying taxes. I think it's a good program, and I also get part of living, and they would probably need more of it if it wasn't for that. I paid for the adult activity center by the regional center, but if they lose their Medicaid clients, they wouldn't have enough resources to keep going, I don't think. So I thought longer than I planned. Thank you.
Thank you, sir.
Hello, my name is Kelly Lewis. I'm 59-year-old woman who lives alone. I don't have family to help me. I suffer from schizophrenia, depression, and have problems with walking because of chronic joint pain. The ADHD nursing monitor my medication, and I receive supportive counseling for my depression. Before coming here, I was hospital 7 times with ADHD service. I have been very stable, low emergency, low 911 call, low hospital. Please don't cut ADHD service. Thank you.
Thank you.
I Ping Chu, Auckland, Hong Kong.
Mr. Ju is ADHD participant. I'm stand here to assist Mr. Ju to voice out his need. Mr. Ju is 83 years old and his wife is 75 years old. They all need ADHD service. Mr. Ju have hypertension, diabetics, hyperlipidemia, osteoporosis, and walk with a walker. And he also have a kidney problem. He need a closely monitor, and then he take 9 medication per day. And he also his wife's primary caregiver, although he have many health problems. His wife suffer a stroke, which paralyzed half of her body, and now is wheelchair bounded. His wife also needs physical therapists to help her exercise and also help her to eat and to toileting. Without the ADHD service, Mr. Ju's wife will need to move to the long-term care, and then they will be forced to apart, like as if they will divorce. Please don't cut ADHD service.
Okay, thank you.
Thank you.
My name is Dawn Myers-Perkey. I'm the program manager at YOLO Adult Day Health Center. I'm also the president of the California Association of Adult Day Services. And I'd like to respond to the concept of transitioning services to other community-based programs. And I brought with me a letter from our county Board of Supervisors, who can't be with you here today because they're in their own dire strategic planning meeting trying to figure out how to fund services. In our county, APS has been decimated. Mental health services are almost non-existent for older adults. Our social services programs have been cut, as has our emergency response. And I want to also point out that the loss of jobs is going to be very, very critical when all these costs are shifted to the county. I also brought with me a letter that was written by a physician and signed by 57 other physicians in our area. And both the Board of Supervisors letter and this letter clearly represents the voice of the each and every county. And I'd like to just share with you.
If you could make it very brief.
I thought I was in comparison. The loss of adult day health will have immediate, catastrophic medical, financial, and emotional effects on the lives of the many individuals who currently attend, and also on the lives of the family. It would be a tremendous loss in an investment in these living laboratories. And lastly, I would call your attention to the article that's attached that was in the Bee today that I think is a great example of why the centers need to stay open.
Thank you very much. I apologize, but the Assembly is back into session. We have to recess, and we will be back as soon as the session is adjourned. Thank you.